Well, good morning, everyone. My name is Karen Freeman Wilson, and I'm the president and CEO of the Chicago Urban League. We are so excited that you have chosen to spend a bit of your morning with us, Monday morning with us, in fact. And as we talk about 340B, and that is the federal rule 340B, and the title of this discussion is Demystifying 340B. And so we know that we have all kinds of folks. We, of course, are joined by some esteemed individuals on our panel, all of whom have the title of doctor. So I feel out-doctored this morning. Some PhDs, some MDs, but we also know that there are a variety of folks in our audience today. And so, what we're going to do is, I am going to just introduce each panelist, ask them to say a bit about themselves, who they are, where they sit, or what they do. And then I'm going to jump right in. It's a conversation, and we look forward to hearing any questions that you may have. Those of you in the audience, please place them in the chat, and we'll be monitoring the chat. And so we are joined by Dr. Sucharita Bowers, as well as Dr. James Brooks and Dr. Cornell Darden today. I'm going to start with asking Dr. Bowers to introduce herself, and then go to Dr. Brooks, and then Dr. Darden. We'll do it in alphabetical order, at least the first time around.
Thank you so much for having me here. It is a true privilege and honor to be here, and I'm representing blackdoctor.org, as well as myself, I'd like to say, as a physician who feels and advocates for health equity. I am a dermatologist. I've been in practice for 16 years. I've been living in the Chicagoland area for the last 4 years. I used to live in Springfield prior to that, and I've been in private practice. In the last 10 years, I've been in academic medicine as faculty, teaching residents and medical students, doing a lot of mentorship work nationally for underrepresented in medicine medical students, and doing work on the regional and national level in health equity, specifically in dermatology, in terms of diversifying our workforce for the purpose of decreasing health disparities across the board, and very much so for our racial and ethnic minority populations. So I'm here to offer my perspectives on 340B, and some of the concerns we have about health equity and how it impacts our communities and our patients. So thank you very much for having me, and I'm happy to be a part of this conversation.
Thank you so much, Dr. Bowers. Dr. Brooks, would you please introduce yourself and your organization?
Hello, I'm glad to be on the call as well. Thank you for hosting me. James Brooks. A little bit about me. I am a pastor in the community, as well as the CEO of Lawndale Christian Health Center. And one thing I love to talk about is that I'm also a resident of North Lawndale. My family has deep roots here, and so I care passionately about my community, and I want to see my neighbors do well and my family do well. So yeah, I've been serving as CEO of Lawndale, which we are a FQHC, a community health center. I've been serving as CEO going on 5 years, and it's been a journey, right? And really concerned about, as I define health, health isn't just what happens in the exam room. It's mostly what happens outside of the exam room. So I like to say, if my community is not well, none of us are well. So we have a lot of work to do, and I'm honored to be on this call.
Thank you for being here. And last but not least, Dr. Darden.
Good morning, everyone. My name is Dr. Cornell Darden Jr. I am the chairman of the Greater Chicagoland Black Chamber of Commerce. We are a public policy think tank and a networking organization with hundreds of business owners as members who really care about public policy and especially healthcare.
Thank you for that, and welcome. Welcome to all of you. And I should raise the fact that this conversation is a part of our health equity and public policy work that we do at the Urban League. We have a research and policy center in addition to the other program areas. And so we're excited to be on. So I'm going to jump right in and just indicate that. The first thing is that there have been a lot of conversations about 340B since its inception. And we know that it is a federal program that was started by the federal government and that it exists in states throughout the US. And it was essentially established to help people gain access to much needed pharmaceutical drugs. And would you talk about that program just generally first from your perspective? And Dr. Bowers, I'm going to go to you first.
Thank you. So I would like to lead with the fact that as a physician and working in this space to advocate for patients, I wasn't even aware of the program. And I think I need to say that because I think that speaks to a big part of the issue around transparency. And being in academic centers, working in the health equity space, and not even knowing about the program until very recently, and then learning about it and how long it's been around and all of the things that have transpired around it, and it's really been alarming to me that I didn't, we're always as physicians who work for the interest of our patients interested in the resources that are available to help them, right? And so we're generally well aware of community resources that are there to help them, particularly avenues to help with the cost of prescription drugs. We know a few things, and we always wish that there was more, but not knowing that there was a federal program and having that not be really in our lexicon at all doesn't allow physicians to be a part of the conversation around it and to really hold these programs accountable. And since, we are caring for patients and the ones prescribing these medications, we need to know what types of programs were designed to help patients so that we can say this isn't working the way it's intended to. So I really want to lead with that, in that not knowing about it, and I've never heard a colleague tell me anything about it. I've asked around since then, nobody knows about it. So I think that really speaks volumes. The second thing I'll say is that the cost of medications is determining whether people live or die. And that is to me, it's one of the it's one of the really hallmarks of the US healthcare system, is that people should not have their life or death determined by the cost of medications, because that entirely removes the possibility of medications helping people. And when we're talking about disparities, where we already know that the cards are stacked up against in so many ways, so many parts of our population, that 80% of their health is determined by things outside of the exam room. Right. So, cost of medications is a huge part of this. So, if there are programs that were designed to do this and those uses are not being used properly, and on top of that, if those monies are being used towards other things that are not helping patients, that's a true structural systemic problem. And so, the people that are involved in patient care really need to be well aware of that, so that B, they can then advocate and help to rectify that.
So, Thank you, Dr. Bowers. And one of the things we know that when it was started in 92, the program was really directed at safety net hospitals. And it's interesting because I've done a lot of work with safety net hospitals during my days in practicing law, and I know how important they are in communities. Um, 30 years after the establishment of the program, there are over 50,000 covered entities and 32,000 contract pharmacies. And so Dr. Brooks, I'm going to ask you, as one of those covered entities that does a tremendous amount of work in the community, do you think the program has evolved in the way that Congress really planned for it to happen in the community?
Right. I would say the Affordable Care Act, expanded the reach of the 340B program
Sure.
by increasing. So it started off just safety nets and community health centers. But what happened, the Affordable Care Act came along and expanded that reach, increasing the number and types of providers that were eligible to participate. So before the ACA, those who were eligible was limited to a smaller group of safety net organizations. The ACA intentionally broadened, right? They said, it's a great program. Well, it's got some flaws, but we got this program. Let's expand the reach. So they included different hospitals that were serving a certain number of Medicaid populations, especially those in low income areas and rural communities. The goal was clear, and it was to extend access and give affordable medications and strengthen care for more underserved populations. The current debate, though, over 340B is largely a dispute between drug manufacturers and hospital systems over the billions of dollars in discounts and how are they accounted for. Community health centers, like I lead, we represent a significantly smaller share of that dollar volume, but we stand to lose the most as the program is being dismantled. If this program was to go away, whether we knew about it or not, it would be detrimental, especially to safety net hospitals and community health centers. This is why I have been advocating for it. It's not a perfect program by no means. It needs some work at the federal level. But if it was to go away today, our safety net hospitals, community hospitals, our community health centers, yeah, we would be devastated. So it's like throwing the baby out with the bathwater.
Thank you. Thank you for that, Dr. Brooks. And thank you for raising, because my question about whether Congress intended, to the extent that Congress passed the ACA, then there is an argument that they did intend to expand the access to 340B. Dr. Darden, and your angle is a little different because you are with the Black Chicagoland Chamber of Commerce. Would you talk about 340B and access to 340B from your perspective?
Yes, from my perspective, I don't remember when 340B first came on our radar, but I want to say about 2, maybe 3 years ago, two Black-owned pharmacists within the city of Chicago have been advocating tremendously to get access to the 340B program. So that's when it really drove home with our members, brought the issue to our attention. especially in Cook County, where there's been a difficult time with the Cook County health system, even having a discussion about the program. So that's what brought it to light. With our research team and doing research on the issue, we've seen a program intended to help give access to patients in lower income communities, safety net hospitals, federally qualified health centers, and things like that. But we've seen a program that's grown far beyond its intent and that is allowing those entities not to be the ones that are benefiting from the program. And it's become a corporate nightmare. I think that healthcare and the price of pharmaceutical drugs are influenced by a number of entities and a number of factors. And I think the current bill in front of the state legislator is not intended to help those entities that need the help and who is intended to help and help the patients.
So let's talk a bit about the uh, individuals who benefit, because we know that with safety net hospitals, we know that the large patient population there are individuals who can't afford to get access health care in other ways and other methods. We know the same is true for the patients that Dr. Brooks serves. When you say that you have a concern that it's not being utilized, we know, well, would you talk about, Dr. Darden, what your specific concern is relative to that utilization?
Well, uh, it's obvious that a lot of people in the community don't know much about the program at all. And when you're talking about discount on medication, sometimes up to 70%, the first thing is okay, is that discount reaching patients? And if the discount is not reaching patients, I think that's the first issue. If anyone's getting any type of discount, a patient should benefit. They should not be paying the same price for medication when discounts are at play. So I think that's the primary issue of our individual voting members of the Chicagoland area who aren't experts on healthcare policy and insurance and all that stuff. So that's just real simple for everyday people. Cut us in or cut it out. How is this even possible? And then when the program is being perverted, where qualified health centers like Mr. Brooks um, has, or safety net hospitals, the intended purpose were for them, no one else. But they're not even getting the lion's share. They're getting a very, very small share of the benefits of this program.
Dr. Bowers, we know also that Illinois House Bill 2371 would prohibit drug manufacturers from restricting which pharmacies safety net providers can use to dispense drugs, 340B drugs from. And supporters argue that manufacturers have really taken advantage of distribution rules to gut the program. And then opponents say the bill would cost Illinois employers nearly 90 million more per year. I know that you offered testimony on House Bill 2371, and it wasn't necessarily for or against, but you were saying that it needs to be studied a bit more. Would you talk about that a bit, please?
Yes. So the program, in terms of it's what it was intended to do is really important. And when you look at the role of federally qualified health centers and what they provide to, like Dr. Brooks, hospital, what they provide to patients, it's indispensable. They care for patients who would not otherwise get care. And when I learned more about this program, what I learned is that there are so many intricacies about it in terms of the flow of dollars that are incredibly complex. And I don't even have a clear understanding around what money is going where, what it's being used for, how exactly it's helping those hospitals that care for patients that need it. How are the patients? That should be the only benefit of this program is it goes to patients and it goes to those communities that need help. And if we don't have, and I say this about a lot of things in medicine, you cannot understand a problem if you don't study it. You cannot understand the ins and outs of how to fix something if you don't have the data around it. And we are tend to be very evidence-based, right? And evidence-based means like what are the metrics around the actual dollars and cents of this program? What are the pharmacies that are impacted by it? We know from the data actually that has been done that pharmacies that are in zip codes that serve, lower income communities have had to be shut down and are not able to provide these benefits to patients in those communities. That's wrong. And meanwhile, there's been an uptick of dollars being invested in already wealthy communities that, from the little bit of data that I've seen, has come out of this program. So why are the dollars that are meant to be helping patients who need this help for paying for medications going not only being taken away from the patients, those communities that need those dollars, but actually increasing the disparity, right? Increasing the disparity even more on both ends. That, I mean, that is so, and I'm not going to mince words here. It's so saddening and angering to me, because that is taking advantage of a federal program. And now what it's doing is it's putting the onus on, and I'm sure we'll get to this later, right, on the state level of how do we then, if the federal government's saying, well, this is the bill, this is the 340B program, but then the communities are left to then figure out what happens on the ground level. If they don't have the money, how are they going to get their patients the assistance that they need? So yes, we need data. There is some data out of North Carolina that looked at how this has impacted North Carolina health centers in those communities and where that money is going. And from what I read, these 340B entities build North Carolina state health plans multiple times the discount. And the revenue generated from this doesn't go to patients. So we have some data from other states, and then we have some data within Illinois. But it's not enough. We need to study that more. And the purpose of studying that then is to then build in transparency and accountability. Because if we have that data, then we can say, okay, this isn't working the way it's supposed to work. And even as a physician who's familiar with policy to some degree and the healthcare system, it is confusing to me, and it is so confusing. And I think that confusion is partly by design, because then we don't really know who to hold accountable. And physicians have, you can't prescribe a medication simply to a patient, right? You have to go through all of these different hoops as it is, and prior authorizations, denials, step therapy. It's already an outlandishly complex system. So now we're also then having to fight against a system that's taking pharmacies out of the equation for our patients. And that's things that physicians don't even know about.
Thank you for that. So we know that there are always opportunities should legislators choose to study something further. You raised the issue of data and the importance of having Illinois specific data. Dr. Brooks, what do you think about that? Would that help the General Assembly to craft a program that could, in fact, be helpful to you and other FQHCs, as well as safety net hospitals and academic medical centers. I mean, because we understand that there is a benefit that comes from our academic medical centers, and we're very fortunate in Chicago to have some amazing centers. So, Dr. Brooks, what do you think about the idea of further studying and maybe crafting something that is better or that meets the needs of what the federal government intended for? And I'll ask both Dr. Brooks and Dr. Darden that question.
Thank you so much. This actually conversation is like a dream for me. But I would like to see more of it happen, especially with our healthcare institutions. That includes, community health centers, private practices, safety net hospitals, and academic hospitals. We all need, I've been preaching this for about a year now. We need to come together and understand how it works. I want to just back up a little bit because I want to just say who it benefits. I am a boots on the ground. I'm a community CEO, and I don't apologize for that. So every day I can see hundreds, I can see thousands of patients who benefit from the program, right? They come to our pharmacy and get a discounted drug. Rather than paying $150, they pay $5. It's the uninsured. Let me say this real quick. We cannot lose. HR1, the big, beautiful bill, it cut funding massively. And in the next couple of months, Medicaid is going to be cut drastically. So if you don't protect what we have with the 340B savings and we get Medicaid cuts, it's going to be detrimental. Okay, so how it benefits patients, I see we have what we call integrated behavioral health. With those dollars, those savings, we're able to offer behavioral health services, transportation assistance, language services. Most of all, as Medicaid gets cut, our uninsured rate has gone up, right? So in order for those folks, 35% of our patients to afford medications, they need 340B savings, right? And that's the benefit of it. So who else do I see benefiting? Our patients who have opioid use disorder. I've seen medication to help them transform their lives. Seniors who would not be able to afford their medications, especially those who are experiencing homelessness. All right. One way that we use this program and the savings from this program is we had a Walgreens to close down in our community, right? And people may not think that this was, some people are okay with that. But we said, no, we cannot have a pharmacy desert in North Lawndale. So we, with some of our other savings and some of the savings of 340B, we purchased the Walgreens building. And now we're adding a pharmacy in our community, so it will not be a pharmacy desert. So I see firsthand as boots on the ground how our patients, how my neighbors, how the members of my church benefit from this program. Is this program perfect? No way. No way. It needs some work, but it's a federal program. All the bill that we have in front of us is calling for is just leave the program alone right now until they work out the kinks at the federal level. Why? Why? Because I'm a FQHC. I'm not a big hospital. I'm not an academic hospital, but I need this program to stay in place because of the continuity of care that our patients receive. Unfortunately, our safety net hospitals, they can't offer all the specialty services that our patients need. So I have to benefit. I got to have a good relationship, not only with Sinai, but with Rush, with Loyola. I got to have that. This gives our patients access So this is why I'm so passionate about the bill. It's not perfect. And one thing I do finally want to say, this bill calls out transparency, right? 2371, Senate Amendment 2. That means it's already gone through the Senate and it was processed there. They had some concerns around transparency and it was corrected, right? Because I want to see bigger hospitals all as well be transparent. I want them to help FQHCs. I want them to help community health centers. I think as boots on the ground, looking at this bill, this is the right step in the right direction, keeping what we have. Because if we lose it right now in December, January, it's going to be devastating to our healthcare system, especially our safety net.
Thanks so much, Dr. Brooks, for telling us and really outlining in detail who benefits. And I think that um, we all want the folks that you outlined, our seniors, those who live in would-be pharmacy deserts, those patients that you serve every day, those patients that are unable to otherwise afford health care. Dr. Darden, would you talk about um, the potential areas of abuse of this program and who the opponents or who the folks on the other side of the debate are concerned about abusing the program and really making the case as to why the program should be limited in a sense.
Well, I think first, it doesn't seem that no one wants the program to go away. The bill is calling for the program to be expanded. I'm not sure why the talking points from the hospitals is about losing the program. Um, the bill, the HB 2371, is looking to expand the program further. ACA expanded the program, and now we're expanding the program even further with this bill. So, who are we expanding the program for? Right? If the program currently isn't helping the federally qualified health centers nor the safety net hospitals, then are we expanding the program for them? Are we expanding it for the uh, big, larger hospital chains? Like, who are we expanding it for? And I think that's where the abuse is coming into play. It's almost as if the larger hospital systems are the ones that are benefiting. The expansion will benefit them, and we're going to still be fighting for our qualified health centers and also our safety net hospitals.
So I don't think that we know that sometimes when things are limited, it does impact the effectiveness or the ability for people to really deliver on programs. So I want to ask this question. Um, what does a perfect world look like? And, I know that might sound um, Pollyannish or just naive in a sense, but what does a perfect world look like with 340B, especially in the context of what we see happening under the big beautiful bill from and I'll start with you, Dr. Darden.
Yeah, if I may, I think the perfect scenario here is to, before we consider expansion, let's get an idea of what we're even dealing with. Let's have transparency put in place first. Let's see where the funds from those discounts are being spent. Are they being spent for hospitals to get involved in real estate and, buy up the block and, pay their CEOs and administrators big bonuses and things like that? Or is it being helped to help? I mean, is it helping to expand healthcare to the communities that deserve it the most? So we want to get a picture of where is the money going, what are we dealing with before we expand the program even further.
So you raise a good point. And it really is a list of or data that includes how the dollars are being used. Because I can make the argument if it's real estate in the right place, particularly underserved communities like North Lawndale, like Grand Crossing, like Chatham, and other places where we do a lot of our programming, then that's an okay use. But to your point, we do need to have a clear understanding of where the dollars or the savings are being invested. What about from your perspective, Dr. Brooks, what's a perfect scenario under 340B once we have the data that I think everyone agrees is important?
Yeah, first of all, just let me just say my perspective on the bill. It's not about expanding 340B. It's keeping in place what we have. Big Farm continues to find loopholes in this program. For example, I won't use the patient's name, but Mother Johnson, who lives right next door to the Walgreens. This was a couple of years ago before they moved. She lived right next door to the Walgreens where she always went to get her medication. All of a sudden, Big Farm put a restriction on it. And they said, you can no longer get your medication, this medication, from this Walgreens. So you have to go to this Walgreens 2 miles away from your home. Right? All this bill is calling for is no, let's keep it as stop with all the restrictions. Stop with this. Our patients need to have access. So what it would look like, accountability, but not just hospitals and health centers and safety nets. But one thing we do not talk about is accountability for Big Pharma. We talk a lot about what CEOs of healthcare centers are making, but do you know how much Big Pharma makes in comparison? It's night and day. And we don't talk about that. And I'm trying to raise the alarm. It's one side that has a lot of money, that have deep pockets, that they can influence narratives, where the other side, all I see is patience. Yeah, maybe you can argue that the CEOs make a lot of money. True. Okay. But I also see thousands of patients going in those doors every day. And I can't say that I have seen Big Farm do anything in my community. I have seen Rush help us with some referrals and help us with the our PACE program for the elderly, help with Sankofa in West Garfield. I have seen that. I have not seen Big Farm do anything. So accountability, yes, but not just on the hospital side, but on Big Farm side as well. How can they make the program has grown tremendously because the cost of medication, they can continue to increase the cost. That's why the program is growing. So, and I think what I would like to see a mandate for us as healthcare providers to come together, webinars such as this, so we can continually learn about the program and the benefit and talk about how organizations are using the savings. One thing that I have appreciated Dr. Darden on from a distance is just the pushback on the program. I appreciate that. Why? Because it has caused me to have deeper conversation with our hospital partners and say, how can we do more? How can you help us do more in North Lawndale? How can you help us do more in Inglewood? How can you help us do more in Austin? So I appreciate the pushback. But right now, the bill that we have, I'm trying my hardest. We gotta protect the program keep Big Farm from nitpicking and restricting access for our patients. And we need to have the transparency there so everybody shares what they're doing with these funds.
So I appreciate your passion and your advocacy. If I put on my big farm hat, and I've never worn it, so I want to give full disclosure. This is not my lane necessarily, but I also know that we have seen certainly during the pandemic and before and since the pandemic, big farm stepping up in a variety of ways. And while those salaries may pale in comparison to anybody on this webinar, and I'm not pocket watching by any stretch, but I just feel safe in saying that.
Look at my
Um,
990. You'll see. Yes.
I also know that research and development, and we saw and continue to see drugs, whether it is COVID uh, drugs or COVID testing or the GLP-1 drugs come to um, market in record time. So, there is I don't want anybody to get the impression that we are here bashing big farm, because we understand that everybody has their place. One of the things you raised, though, Dr. Brooks, that I think is extremely, extremely critical, and I want to go back to Dr. Bowers on this, is the ability of entities from every sector to sit down, not just on webinars, but in rooms, in places outside even of the General Assembly, to have conversations that says, these are our concerns. How do we address those concerns so that it benefits the patients who everyone is looking to benefit? What do you think about that, Dr. Bowers?
I have to start by saying I'm like elated that I get to be a part of this conversation because this is like everything about my ethos as a physician. And I feel like I have been screaming this as a doctor, as an immigrant myself, first generation US college student, first generation physician, immigrant from India. My parents came here with nothing. Um, I and as an individual, as a human, the reason I went into medicine is for the singular goal of making people's lives better. And I have kept that goal. But what I have noticed is as I've gotten further and further in my career, gotten a really upfront and personal taste around the fact that there's very many different goals in healthcare. And we aren't speaking the same language all the time with all of these other players. And that's a huge problem because if we're going to solve any problem, just like I talked about, we need the data around it. We need to be in agreement on the goal. And I think that there's so many different goals with all the different players in healthcare. And so when you have, individuals such as myself and so many other of my colleagues that I've learned from as well who are working in the health equity space, the fundamental um, need here is for connection and us to have conversation and dialogue because I have never been able to sit down with Dr. Brooks or someone like Dr. Brooks or Dr. Darden with someone like Dr. Darden. I haven't been able to be in these spaces, and women and minorities, Black and brown folks, like we aren't traditionally invited to these tables. And being at working in many different hospitals, most of the hospital administrators I have been in leadership in academic medicine, and even I am like, you have got to follow the chain of command. You can't talk to the person up here because there's all these different, barriers in between. But I'm treating the patients. Like I'm getting a firsthand look at like what are the problems that my patients are facing. And so it's really important that I get to the person who's talking, who's dealing with the patients, that I get to talk with the people up here, and that all the people up here are talking with all the other people around here, out in healthcare. And that to me is really the fundamental problem, one of the problems in our healthcare system. There's a lot of fundamental problems in terms of structure and the system. But there's so much we can learn from each other. To be able to hear you, Dr. Brooks, and tell me exactly, not only from your CEO perspective, right? But as a member of the community, as a leader in your community, both in your space as well as a community member, having that direct vantage point of here's how this program helps my community and the patients who come into my hospital. Why are we not? I mean, and I feel so validated sitting here within this conversation because oftentimes as women, we say these things and it's like, it sounds, idealistic or, like, stay in your place, right? Stay in your lane. But like healthcare and patients' lives, this is, if we're working in that system, we should all have that same goal, right? And all of our lanes should sort of be, interacting with each other. And so we don't have these conversations, and I don't hear, as a physician, I don't get to share my perspective with the hospital CEO and the pharmacy, the big pharma CEO, who's then, in charge of everyone below that, below him or her. It's how processes and protocols work. How are we ever going to get on the same goal? And to me, this is a fundamental problem, is a lack of connection, a lack of learning from each other, and having really true, honest conversations, right? Not just PowerPoint presentations or things like that, but really true, honest dialogue and what works for people and what's not working for people. Because the bill and the 340B program is an important program. And that program, wherever it's not working, it needs to work. And wherever it's working, it needs to stay. And then wherever people don't know about it, they need to be able to know about it so they can advocate for the things that aren't working. And we can do so much, right, as professionals and being able to like connect and have this conversation, but those spaces just never seem to really happen. So I feel, to me, I am so validated by being able to have this conversation and get to and to hear the perspectives, and to see actually so many of us are saying the same thing. And it's how we work together. Because then again, not to get too far off topic, but when we work together, we have more ability to change that system. So you have the physician perspective, you have the community perspective, leader perspective, you have the hospital CEO perspective, and how important it is for us to have the ear of big pharma. Because, like, here's another thing: we have to work together with pharma, but like they are, if we're not working together, then we'll continue to have things like what's happening, which is, saying you can't use this pharmacy. Like that's just not okay. And so to be able to hold pharma accountable, we actually need to have interactions with pharma and then say, look, here's what your processes are doing. They're hurting people. And for me, my lens is always, how do we speak to each other's humanity? Right? It's there for most people, not everybody, as we've seen, but it's there for most people. So yeah, I that's sort of in an ideal world, to answer your question that you had said, in an ideal world, we would have clarity on our goals. And we would have shared goals that we work on, right? And that we would have the courage to talk to each other and learn and listen to each other and to find where those commonalities converge, so how we can make things better for that shared goal. And so that's what I feel would be, in an ideal world. So that the ultimate goal would be people's lives improve. It's really simple.
Thank you for just in a very the teacher in you came out and you gave us the blueprint for that. I often wonder how many more challenges we could resolve through clear and open communication. And quite frankly, that is why the Chicago Urban League is engaged in the work that we do around health equity, because we know, and just about general equity and social justice, it's because we know that people don't always have all of the information that they need. And we knew that people didn't necessarily have everything that they needed to know about 340B or certainly about HB 2371. So we've got 4 minutes. We don't have any questions in our chat, but we've had a vibrant conversation. And so the question is, and because this will be shared out multiple times, where do we go from here? We know that there is a bill pending. We know that there is a program operating, and and what can we do to ensure that our patients are cared for? And I'm going to start with you, Dr. Brooks, because you mentioned letting the feds resolve it. And I thought, now that's interesting because they've not been able to do much of anything of late. So why don't you talk about where we go from here?
The reason I said that, thanks for this, is because it's a federal program, right? And all like 22 other states, the bill is just asking Illinois to protect what we have right now. And then and protect us from the continued restrictions that keep coming upon us. And as a member of my community, we just can't have it. We can't have it. People need access to their medications. And that's all this bill to me, and the transparency that it offers that we've never had before is offering at the state level. I think that's what the state can do. And it's zero cost to the state to do this. It's just passing the bill to protect it. 22 other states, red and blue states, have passed this protection. Zero cost, right? But I think, to Dr. Bauer's point, I get emotional because I've been screaming. I've been I've been yelling, like crying out about, this program and how important it is. But however, when you really look at the overall percentage of the budget, 340B, the benefit that a hospital receives and that a FQ, it's not that much, right? Single digit percentage, right? We got bigger issues that I hope, Dr. Darden and Dr. Bowers, we could come around. Medicaid rates, right? PPS rates. It's ridiculous. That's really, when you think about equity, you're like, come on. Yeah, I won't go there since we're talking about 340B.
That's
But
right.
340B is critical. But we need to come together because we are better together, and we need to learn from each other. And yes, I want to include Big Farm at the table as well, but I'm just calling for accountability all the way around.
We need some 365-degree accountability, not just
Yes,
one-sided.
yes.
Agreed, 100%. Dr. Darden, looks like you get the final word. Actually, I do, but you get the final word before it comes back to me.
Yeah, well, when it comes to the federal approach and this hodgepodge of regulations by state, the chamber is always wary of that, whether it's on a medical issue or technology issue, what have you. That is confusion that raises prices. That's just basic economics. Anytime we have confusion from state to state, we make the execution more complicated, which rises the price of medication. This is a federal issue. It should remain a federal issue, and that we should advocate to fix whatever issues are at the federal level. I do know that the biggest question with HB 2371, the hospitals are saying that we need to pass this bill to save the 340B program, or we're all going to close. Well, if the program is consistently expanding, or is the program going away? Because that's a question that hasn't clearly been answered from their side. And then also, when it comes to the price increase with this bill. CMS put a study out, I believe it was Monday, and CMS, which is a State Department, commented on the increase that the program's consistent expanding in ways that it wasn't intended to expand is causing stress on the state to the tune of $200 million and another 100 million or so if this bill is passed.
Well, first and
This
foremost,
is where I hear don't be heard. I don't not heard as a black CEO that's in healthcare. I'm telling you what it is. I'm
I,
telling you, it's we're not expanding the program. Please listen to me.
I understand that. And here's what I would say to you all. We have to keep talking and keep talking with the patient, the end patient in mind. I want to thank each and every one of you for being on, for providing information to the attendees on our webinar today. And most importantly, I want to thank you for what you do in the community. I understand what it means to be a leader and to have to advocate on behalf of tough issues that everyone does not understand. And just know that you are appreciated and that the Chicago Urban League remains a resource for you and for everyone else in the community. In closing, I would be remiss this evening at our site at 8331 South Stewart. We have a town hall, and it is a town hall about democracy. And that is probably why I asked the question, do we really want to leave this to our members of Congress? Because we know that there have been some challenges here lately. But we're going to talk about how we can use our voices, not just at the federal level, but at the local, state, and federal level. This is directed to folks who might not otherwise be in Springfield testifying or lobbying. In fact, we are going to have musical guests, and I'm pulling it up because they are not in my regular rotation on my playlist, but we are going to have Little Mu, Zion Ali,
Oh,
and Kent Bydeen. And Binky is also going to be providing entertainment, but we are going to hear a rich conversation from National Urban League CEO Mark Morial, our County Clerk Monica Gordon, Reverend Sierra Bates Chamberlain, Stevie Vallis from Chicago Votes, and they will be moderated by Africa Porter. So that's this evening. And then tomorrow morning, we're going to run it back with a morning conversation with our own Attorney General Kwame Raoul and our National Urban League CEO Mark Morial, and they will be moderated by our sister Kiana Barrett, who's the president and CEO of the BLC. So we've got a busy 2 days, not to mention everything else that is going on. I want to thank everyone again, and I want to give a special thank you and shout out to Pam Stalling, who has been our technical assistant behind the scenes and has worked with us to make sure that this went on Zoom. So thank you, thank you, thank you, and have a wonderful day.
thank
Thank you.
you.
All right, take care.